Hey everyone, this is Professor Rivera-Mitu. Welcome to this overview of depressive disorders according to the DSM-5. In this presentation, we'll break down the different types of depression that clinicians and mental health professionals need to recognize, differentiate, and diagnose accurately. Depression isn't a one-size-fits-all condition. The DSM-5 outlines several distinct depressive disorders, each with unique characteristics, durations, and diagnostic criteria. We'll walk through major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, disruptive mood dysregulation disorder, and others focusing on what sets them apart in terms of onset, duration, symptom patterns, and functional impact. As future PMHNPs or mental health professionals, your ability to identify and differentiate these disorders will directly influence your diagnostic accuracy, treatment planning, and outcomes. We'll also review mnemonics, DSM-based criteria, and case clues to help prepare you for clinical practice and the ANCC board exam. Let's begin by taking a closer look at major depressive disorder, the most commonly diagnosed form of depression. Major depressive disorder is the classic form of clinical depression. This diagnosis requires at least 5 symptoms over a 2-week period, with one being either depressed mood or anhedonia. It's important to emphasize the episodic nature of MDD. Patients often describe feeling down or numb, and the condition interferes significantly with social, occupational, or academic functioning. Always rule out bereavement, substance-induced mood changes, and medical causes before assigning this diagnosis. For boards, remember SAGI-CAPS is your best friend for remembering symptom criteria. So in the mnemonic SAGI-CAPS, it stands for sleep changes, interest loss, guilt, energy loss, concentration problems, appetite change, psychomotor changes, and suicidal thoughts. Now let's talk about persistent depressive disorder, or otherwise known as dysthymia. This is a more chronic but less intense form of depression. Think of it as a lingering sadness that never quite lifts. Patient must experience a depressed mood for at least 2 years, or 1 year in children or adolescents, along with 2 or more additional symptoms like fatigue, low self-esteem, or hopelessness. The key difference from MDD is duration. This is chronic. Also, patients must not be symptom-free for more than 2 months at a time. Many will say, I've always been this way. For the exam, know this is commonly comorbid with MDD, termed double depression. You can try and remember this by remembering the mnemonic, he's too sad, hopeless, energy loss, self-esteem low, 2 years minimum, sleep change, appetite change, and decision-making difficulty. DMDD, or Disruptive Mood Dysregulation Disorder, is a pediatric diagnosis for children between ages 6 to 18 who present with chronic irritability and frequent temper outbursts. This was introduced to reduce overdiagnosis of pediatric bipolar disorder. Key points are symptoms lasting 12 months or more, occurring in at least 2 settings, and onset before age 10. These children are often misdiagnosed with ODD, ADHD, or bipolar disorder. For boards, remember this is not episodic. The irritability is persistent. The key phrase to remember is the child with outbursts 3 times a week and angry in between. Premenstrual dysphoric disorder, or PMDD, is a cyclical mood disorder tied to the luteal phase of the menstrual cycle. Symptoms must appear a week before menses and resolve a few days after menstruation begins. You need at least 5 symptoms, including at least one mood-related symptom. This diagnosis requires prospective daily tracking over at least 2 cycles. PMDD is more severe than PMS and can include suicidal ideation. SSRIs like fluoxetine are first line. On the boards, look for timing clues and affective symptoms, not just bloating or cramps. You want to remember the mnemonic mood plus body. So the patient will have mood swings, irritability, depression, or anxiety, plus bodily symptoms such as bloating, breast tenderness, appetite changes, and sleep issues. Substance or medication-induced depressive disorder applies when depressive symptoms are directly caused by a substance, such as alcohol, benzos, steroids, or withdrawal from stimulants. Timing is essential. The mood change must emerge during or soon after use or withdrawal. The substance must be known to cause depressive symptoms, and the full syndrome mirrors MDD. For exams, be alert to questions with timing clues and medication lists. This is not diagnosed if symptoms only occur during intoxication unless they persist. Some red flags to remember: the patient started after prednisone, the symptoms started after prednisone, heavy drinking, or resolved after stopping the medication. A depressive disorder due to another medical condition applies when depression is caused by a medical condition such as hypothyroidism, Parkinson's, MS, or stroke. DSM-5 requires clear evidence of a pathophysiological connection. You won't make this diagnosis if the depression predates the illness. On exams, look for case vignettes involving weight gain, cold intolerance, fatigue, and depression. This often points to hypothyroidism. Always consider labs and imaging when depression presents atypically. You want to look for phrases like recent stroke, thyroid imbalance, or neurologic symptoms. This last category of other specified depressive disorder or unspecified depressive disorder are used when symptoms are present and clinically significant, but they don't meet the full criteria for a specific depressive disorder. For example, if a person has 3 MDD symptoms for 10 days, or brief but recurrent depressive episodes. The difference between specified and unspecified lies in documentation. Specified is used when you name the reason criteria aren't met. Unspecified when you don't. Boards may include these to test your understanding of subthreshold diagnoses. Some examples: 4-day depressive episode, improves spontaneously, or symptoms post bereavement. This comparison table is crucial for differentiating types of depression. Focus on duration, onset, and distinct features. For instance, MDD is acute but severe, while PDD is chronic but less intense. PMDD is clearly tied to menstrual cycles. DMDD is pediatric and non-episodic. Understanding course and context helps avoid misdiagnosis. Be sure to know which require 2 years, which are time limited, and which are situational or induced. This slide is your cheat sheet for board questions. Another board tip: DSM loves asking about duration, age of onset, and differential diagnoses. Thank you for watching. If you found this video helpful, please give it a thumbs up, subscribe to my channel, and share it with your fellow nursing students. Your support helps me reach more students and provide valuable content. Remember to subscribe to my channel to be the first to know about more test-taking strategies and concept map videos for different diseases. Remember, together we can make a difference in our nursing journey. Until next time, this is Professor Rivera-Mitu. Stay curious, stay compassionate, and keep learning. See you next time.